Thank you, Tiffany, again, for sharing your story and taking the time to be here today. Before we move on to our next presentation, I just want to take a quick minute to cover some housekeeping items. So breakfast will remain in the hall till 9:45 in the morning. So if you didn't get a chance to grab something, feel free to step out and do that. We'll have some light snacks available after that until lunch is served around 12:30. So everyone also should have received a welcome packet as they came in. If you didn't pick one up, there are definitely more still out in the lobby. You'll find some helpful information like the run of show, a QR code that links to our website, and some of those preliminary evaluation results that we mentioned earlier. So after each presentation and panel is done, we're going to have about 15 minutes for Q&A from you all. And so there are going to be some floor mics placed out that you can use if you have any questions. You can also text your questions in if you prefer to the number on the screen. It's also in your welcome packet. If we have time after people finish asking their questions from the audience, we might pull some of those that are texted in. And then if you're taking any photos of your time here today, feel free to tag your photos with the hashtag ED Symposium so we can check them out later. And with that, I will turn it over to our first presenter. So really pleased to introduce Dr. William Beecroft, who will be presenting on billing and sustainability. So Dr. William Beecroft is currently responsible for the Behavioral Health Medical Administration of the Blue Cross and Blue Shield of Michigan Behavioral Health Strategy and Planning Team. He is a strong advocate for the collaborative care model expansion, crisis services, adult and child intensive services, and first episode psychosis programming. Dr. Beecroft received his Doctor of Medicine from Michigan State University. He is board certified in general psychiatry with added qualifications in geriatrics and consultation liaison psychiatry. Dr. Beecroft is also the vice president of the Michigan Psychiatric Society, and he was named a Distinguished Life Fellow of the American Psychiatric Association in 2018, and recently he was also named the National Alliance on Mental Health Illness 2023 Lifetime Achievement Award recipient. Thank you, Dr. Beecroft, for taking the time for being here today.
Well, good morning. Good morning, and thank you for your time. And thank you for all the innovative work that everyone in this room is doing. One of the psychotherapy techniques that has kind of gone by the wayside but really helps people on Monday mornings is what's called bioenergetics. So why don't you give a hand to yourself, because you are the ones that have been doing this work. Congratulations on getting this far with these programs. These are really transformative techniques and skills, and really moving and advancing medicine substantially further than where it was 3 years ago. So take that away from today, is that you're really leaders in the area of medicine and science, and being able to help our society really move forward. We've got a lot of transformative things that are happening in medicine here in the last couple years. So today we're going to be looking at several different things. How to be able to move from grant funding to moving into sustainability. Kind of a boring thing to talk about on early Monday morning, but I'll try to make it as exciting as it is possible here, because it really is important stuff. We really have to shift gears to move forward with this. So what's the problem? Being able to look at, and in my practice, I practiced in Lansing for 38 years. As a consultation liaison psychiatrist, I spent a lot of time in the emergency room. Probably a quarter of my time was dealing with substance use disorder. We didn't have as much opioid use disorder in my early days, but by the time I ended up moving to Blue Cross, it was really quite substantial. And the tools that I had were nowhere near what you have now. So that is really a significant move forward. What we do know about the use of MOUD is that if people stay on the medications and stay on the treatment for 2 years, they can get to the point of approximating almost a naive level of relapse with opioids. It'll never get back to zero. Because they've really changed their biochemistry and their neuroanatomy. But it gets pretty close to that, so it's really important to be able to get to that point. And that back in 2015, the JAMA really looked at the people that had gone in the emergency room and had opioid use treatment there, had a substantial improvement of remission than what people that had standard care would do. What I always saw was the difficulty of being able to get people admitted from the emergency room to a residential program or substance use disorder program, especially if they had Medicaid or no insurance. That was almost impossible to do. So what I worked with my colleagues in the emergency room is treat people in place. We would stabilize them, get them to the observation unit, do any detox that we would have to do, and then work from there to arrange outpatients. So when this came along, back 2015, 14, somewhere in there, it was really, this is good stuff, to be able to have this option to be able to take care of people. So I'll move right into this because we've got time issues. I'm not going to try to train you in the protocol. You all know the protocol. But being able to look at opioid use disorder as a mixture, about 5% of people are a pure opioid use disorder. 80%-ish are in the mixed use disorder category. So you're not always dealing with just an opioid. You're dealing with a benzodiazepine on top of it, some cocaine, some marijuana, some methamphetamine. So being able to look at the entirety of the individual is really the important piece here. But then identify the pieces that you can treat in the emergency room or the major piece. And if it's opioid use disorder, you've got some additional tools with Suboxone and also the naltrexone products that can be used as well. Again, people that are relatively stable, the mild people, you can be able to start them on some oral medications and be able to get them out of the emergency room with a follow-up. Whereas others that have to have some stabilization, you can use the oral Suboxone products and then be able to move them forward with outpatient follow-up as well. But being able to assess, kind of have to figure out which way I'm at. Being able to assess what's going on for them, being able to get a system in place, which is what this has done, that you can be able to discharge them somewhere where you know they're going to be able to get a continuing protocol of treatment. And that's where we're really going to focus most of our time today, is in that continuing protocol. But it is important to also look at, this is expensive work to do in an emergency room. Yes, indeed, you do have your emergency room codes that you can use, but they aren't enough to be able to help address the psychosocial needs of the individual, spend time on that more thorough assessment, and be able to get them the warm transfer to the next service that is going to be able to pick up the ball and run with it, to be able to keep them on track and keep them on course. It's not just the drugs. It's looking at being able to help them understand the disease, being able to help them be educated in that area, the need for psychosocial treatment and services, and being able to also move forward with the getting follow-up with the medications in and of themselves. Housing is a big issue as well, but being able to look at enhancing those support systems that's there, and being able to use case management, which I'll be talking about. So what can you do in the emergency room itself? And I will have to pull out my phone because I can't read that down there as far as the numbers. But we do have additional codes that you can use in the emergency room. Let me get to them. So the one that's most predominant is the G2213, and this is billed in the emergency room to be able to do all these things that I was talking to you about, to spend more time being able to really assist with getting people on track, being able to get all of these systems put together and then move on. These can be billed with the regular emergency room codes, so they're not separate from that. Yeah, okay, you're still on the same one. Okay. But they are limited to one use per day. I don't have the pricing of what they are, but that is something that we need feedback as a company, Blue Cross Blue Shield does, and probably other payers do as well, of what is that reimbursement adequate? If it's not, give us the reasons why it's not adequate, and that's something that we can work with to be able to make sure that it is adequate to be able to suit the needs of the time that's spent and the personnel that's spent in the emergency room. Now, if someone else has been able to see the patient, say they went to another emergency room before they came to yours, and somebody else went through all these steps and billed this code, it would not pay for the second emergency room to bill that code. So that is a downfall of this code. But that also is really important for your history taking, to be able to know, were you somewhere else before you came here, to be able to move forward with that. What I'll move into is, what's the next step though? How does this sustainable on a long-term basis? And the use of transitional care codes are a case management code. There also is another code that is payable not only in commercial payers, but also with Medicare and I believe Medicaid as well, is the chronic complex care management codes. The difference is that the transitional care codes are for basically a month, the first month of treatment. You really have to have a physician's order to start this process, to be able to get into this care management. But then you look at the care manager is a face-to-face interaction. It's not just a telephone call, or it could be done by video conferencing, so that's a possibility. But it is a face-to-face relationship that is built with that person. In doing this, it really is important because you're leveraging that relationship to be able to move forward. People will tell you all kinds of things on the phone and they won't do them. Whereas if they have to talk to you and look you in the eye, they're more likely to actually do it when they develop that relationship with you. So you're using that in a positive way. Has to be started within 14 days of discharge. It can be started even before discharge. So this is something that could be done technically probably in the emergency room, and then be able to have at least that relationship started and then move on from there. The chronic complex care management codes I know can be used in either the inpatient stay in a hospital setting, in an observation unit, or the emergency room to be able to do that same kind of service. With that, then you can be able to move forward with addressing the social determinants of health, looking at the barriers of care, looking at the co-pays for the medications that you have prescribed in the emergency room, to be able to look at programs that can be able to pay for those, or other systems issues that might be able to be a workaround to be able to get those benefits paid for. Now, one of the things that I will put a pitch in here is that the long-acting injectable versions of these medications are on Blue Cross's formulary. Both the Suboxone buprenorphine products and the naltrexone products. The nice thing about long-acting injectable medications is that they're binary. They either took the shot or they didn't take the shot. We know the pharmacology. They last about a month. Some people with Vivitrol, it's 3 weeks. Some people are 5 weeks. But Suboxone's pretty clear, and Probufen and Sublocade are pretty clear that they stay in the system for about a month, pretty consistently across different people. So then you know when the next appointment needs to be to get the next shot. That's really the important piece on using the injections. With the injectables for us, they are, and when I say us, I'm referring to Blue Cross. They are a medical pharmacy drug, and if you've sufficiently paid your co-insurance and copay for the year, which is 1 ER visit, by the way, you basically have free medicine for the rest of that year. So it eliminates that copay or that barrier. We've tried to make it really quite easy. We also have, it's an infusion, so basically infusion centers. We have some that are doing this work. We have visiting nurses that can go out to the home and do the injections in some areas. So these are things that can be done, and these are also things that the primary care doctor can do in their office. These usually are their patients. So they may do that for you. So again, coordinating that's where the transitional care management can really help to make these kinds of things real and make them happen. I knew I should have printed off my PowerPoint. So the other thing is how to build these codes. They are built on a once per month basis. I think this is back one. No? And so basically you keep track of the time that's spent for these particular codes. And then the code is there that you see. Roughly they're in the $205 range nationally. There's variation between different plans, and that's kind of an average that I was able to find over time. You can continue this for essentially the first month, and then after that they need to transition to those other codes that I was talking to you about, the chronic complex care management codes. And that 205 is per unit. Per unit is 1 hour, so if you have multiple hours, you would bill that in that 1 month period of time. The OTC and the OTP codes, the outpatient opioid treatment codes and the opioid treatment program codes were brought out in about 2017-18. And these are two different sets of codes. The OTC codes, which is opioid treatment codes, these are payable to a primary care doctor, an addictionologist, any MDDO can be able to prescribe these and get paid for these. They also can be billed for by nurse practitioners and PAs as well, either independently or within their scope of practice or under supervision. But the OTC codes basically are a bundled code of a variety of services. They are for 1 month period of time, and so you keep track of all of the units that you use over that period of time. But they have group therapies, they have social work support, other support systems that kind of are built into this and payable with these codes that you're using. The nice thing is that they are structured in such a way that you can then work with other systems as well to be able to do outpatient therapy, group therapies, and then use community resources, NA, AA, whatever the other community resources that you're going to want to use. The opioid treatment programs in the past would have been considered methadone clinics. These are SAMHSA certified programs that fit the more stringent criteria that was left over from the methadone clinic days. And with these, there are roughly, I think there's 14 of these codes. They include the medication as part of the payment. So that makes it a really very good way of being able to get one-stop shopping. You get the administration fee, you get group therapy, the education services, the social work services, case management services, and the medications are then bundled with that. So it makes it relatively easy to do, and they're paid weekly. That's the difference between these. These are weekly codes versus the OTC codes being monthly codes. Because they include the medications, and they're also codes that can be able to use the long-acting injectables, they take a little bit more time to be able to do. That also is a way to be able to make this sustainable on a long-term basis. So that's the codes that we have to really start things. Now I will move into another area that is really important, is how do you be able to sustain this over a longer period of time? Getting back to that 2-year window, we want people to stay in treatment at least 2 years, especially on the long-acting medications. Lifetime is where we really think people really should be. And continued engagement is really the key to being able to keep people well and keep them on course with these illnesses. So with that, the collaborative care model is a program that primarily works with the primary care provider, but it can work with addictionologists, it can work with other specialists as well, and I'll get into that in a minute. But it is led by a medical lead. It can be led by NPs and PAs as well, but generally we're looking at an MD being the lead of that medical team. The addition to that is the psychiatrist consulting and also the behavioral health care manager that are embedded in the team. The psychiatric consultant does not see the patients directly. They see the cases and they work with the behavioral health care manager and I will say primary care doctor, the primary care provider, in partnership to take care of that patient. But they're reviewing all of the cases that screen into this program every week. So they're also screening for behavioral health conditions, also meaning mental health conditions and substance use disorder. So if we know that about 70% of people that have a substance use disorder also have a primary mental health condition as well. So if you don't take care of both of them, you're lost. Also, we know that many of people that have substance use disorder also have significant medical problems. And with that, they're also looking at the interaction with the medical problems and the behavioral health and substance use disorder all in combination. So it is a very highly integrated method of being able to take care of people. Blue Cross, with our training partners, both the Michigan Institute for Clinical Systems Improvement on the west side of Michigan and also University of Michigan, have developed a curriculum of what we train for collaborative care that also focuses specifically on substance use disorder. The literature that I would refer you to is the Summit study that was recently finished back in about 2020. They started it in about 16, and they had some preliminary studies that were done. It's been repeated. But this is where they use the collaborative care system to be able to treat people with opioid use disorder and substance use disorder in general. Also, alcohol use disorder was a big focus for them in that study. And they had roughly a 35% remission rate that was sustained, which is pretty substantial. You take a 35%, that's not very much in medicine. But when you look at treatment as usual, having a 5% remission rate at 2 years, that's a lot, 30% more. Now, collaborative care is a payable code, both in Medicare, Medicaid, and in our commercial product. I think it is basically in most of the commercial payers in Michigan now, moving forward. But the thing that's always kind of presented, is the impact study. And this was actually looking at the medical costs of people with a behavioral health condition. And they were focusing on depression and diabetes primarily. But what was found is that there was roughly a 2 to 1 return on investment for the just treating the behavioral health aspects of people's care. The behavioral health part of people's care is about 5% when you look at the overall costs. They're huge costs, but it's still only about 5%. The medical care is the 95%. So the money is really in the medical side and prevention of the liver transplants, the pancreatitis, the COPD that goes along with smoking too much, and the methamphetamine getting into difficulty with heart disease. So this collaborative care really does help look at taming that aspect of the care, getting better people with better medical care so they live longer, they live better quality of lives, they can get back to work. They also keeping their substance use disorder under control and their behavioral health, their mental health conditions under control as well, helps them to be able to have a better quality of life and become productive members of our society again, which is where we want people to be able to have those kinds of skills and those life experiences. So I think I've kind of hit on the major benefits of the collaborative care. But with that, does that bring up any questions for you of why I shifted gears from just doing the immediacy to now shifting gears into long term? And I'll kind of open it up for a couple questions here, and then I'll move on to some other things about looking at. Okay, one in the back.
morning. I'm an emergency physician in Grand Rapids, and I'm just wondering, how do you see the emergency department starting this process? Like who does the initial assessment in the emergency department and starts the billing process so that these codes can be initiated for hospital systems?
Well, in general, I would think, and all of you probably have little variations in your protocol of who does this already, but I would think you'd want this, the initial medical evaluation, obviously, emergency room physician or your PA that's working with you to be able to kind of give you the presentation of what's going on, a little bit of the history of what they've had as far as treatment before, what's worked, what hasn't worked, and then kind of go from there. You need to get the psychosocial part also addressed. And nursing staff can do that very, very well. There's a lot of well-trained nurses that can do this. A LMSW, LPC, or an LMFT can also do these kinds of work. We really like to use I say we, in my past, I really like to use LMSWs because they have the training across medicine and the mental health and substance use disorder spheres. But once you get somebody that is trained to do this and does it well, you have a consistent product from them. You can really do great work with having that kind of a team together. And it is a team. Yeah, now we're in the back.
All right. Thank you very much. I really appreciate your talk this morning, as this is something that our hospital is currently working on and figuring out how to move from a grant-funded, philanthropic-based program to something that is long-term sustainability. I apologize to everyone in the room for this, but I do have a coding and billing question, just something I hope that you could help to clarify for me. So on these transitional care management codes, is that work that needs to be specifically performed by the treating physician, or could a nursing care manager be able to complete that work and still be able to code for that?
Yeah, it has to be ordered by a physician or a medical provider and then accomplished by the behavioral health care manager, whoever you chose that to be. And those billings actually work their way back up through the physician lead. So it's billed by the physician.
Thank you. That was my secondary question. So it sounds like that's part of the professional fee then, as part of that billing. Okay.
No.
Yeah.
I have one over here. I got some other things to talk to you about, but I just took a little break for questions for where we got to in collaborative care. So here we go.
I just had a quick question. You were talking about the long-acting injectable buprenorphine and having, sounded like you said, nurses going to the patient's home. Oh, thank you. The patient's home to deliver the injection. How do you get around the DEA regulation that does not permit us to transport that medication? So far, we are required to deliver it where the DEA is tied to, so that you have to deliver it to where you are delivering that medication to the DEA prescriber's location.
Good question. I don't know. I know they do it for us, and much of this comes from the use of long-acting injectable antipsychotic medications, which don't have that restriction.
Okay. I know there's discussion.
These are packaged and they're
okay. I know there's discussion
secured
about allowing that to happen, but so far not allowable by the DEA yet.
Okay. I'll have to check that out.
Okay.
Thanks for that piece of information. It's one of those barriers to healthcare that we have to address. Okay, moving right along. We have a program at Blue Cross that we've called the Adult Intensive Services Program. And we also have a Child Intensive Services Program as well. It primarily was developed as a wraparound services for individuals that really needed that more chronic case management. They do use the chronic complex case management codes that I was telling you about earlier, but do all of those things that are kind of outlined in that, of eliminating the social determinants of health as much as we possibly can, looking at the barriers of healthcare, being able to look at logistics. For the mental health side, if they're on a involuntary committal or an ATO, helping that to be staying in place. Substance use disorder also has this option, as you know, so they could be able to do the same sort of court work to be able to continue that order in place. those sorts of things. But the whole key here is that this is boots on the ground, face-to-face case management that can be able to keep people well once they get stabilized, make sure that they get to their therapy appointments, make sure that they make their community resources appointments, being able to make sure they get their shots on time, these sorts of things. They can, with a community health worker, have them go to the doctor's office and make sure they get the shot. So those kinds of things can be really very helpful in this program. And as I said earlier, it's payable in our program, but it also is a Medicare payable service. So this is something that can be helpful. It won't go underneath that acronym. It would go underneath the code of the chronic complex care management. But you have to have a physician order it, just like the transitional care codes. And the key that is a little bit different here is you have a community health worker. That's the term I need to use because it's in the definition of the code. The community health worker can be trained on substance use disorder issues and be able to support that individual. They could also be trained on other issues like first episode psychosis, about the importance of the tools that they need as well. So there's a lot of flexibility in this program of how to be able to help with this. And what you have in this is you have the physician that's could be an MPPA as well, that can be able to order this program. Then you have a coordinator basically making sure everybody's getting where they need to be. But the behavioral health care manager is the one that's really the key to making all of this work. They're the one that has the face-to-face relationship. They can go out to the home. They could be able to do telephone rounds, if you want to think about it that way. They can work with the pharmacy to be able to get a Dividose pack of medications for them, whatever they need. And then the community health worker, as I say, is kind of the jack of all trades, being able to make sure that that's the glue that really holds all of this system together. We can't pay for peer support yet because they're not actually a licensed provider. And this is a way of being able to get this peer support component of care wrapped into the entire individual's care. We don't have the, kind of going ahead here, the AIS and CIS programming around the state completely, but we have roughly 17 counties covered with this already, which is a substantial move forward, and we're continuing to recruit new providers going forward. The Crisis Services is the most new program that Blue Cross has been working on, but we know in the public system this has been available for the last 30, 35 years. It works really, really well. Mobile crisis, crisis stabilization are the two new components. Crisis stabilization is going through specification development through the state of Michigan. So is available in 2 centers, but there's several centers around the state that are poised with hammer in hand to be able to build the units as soon as those specifications are released, which will be really helpful. The way of thinking about this, and I'm jumping ahead a little bit, is the crisis stabilization unit is kind of like that med-surg observation unit that I used to practice in. It's focused on psychiatric needs, on the behavioral health need of the individual, and it does avert going to the emergency room. Not so much that the emergency room is not really important, it is, and it's life-saving. But for people that have a primary behavioral health condition and no real significant medical issues, going directly to where they can get direct treatment for those services is really key for them. And they can be able to see a therapist usually within anywhere from a half hour to an hour or so to be able to do an initial triage assessment and then go from there, see a psychiatrist if they need to. And then whatever services for diagnosis and treatment, initiating treatment in that facility is really key to this. The mobile crisis, I'll step back a little bit, is where a master's level provider and a peer support go out to an individual wherever they are. Could be in an emergency room. If some of the emergency rooms don't have behavioral health consultants or assistants, they could actually go there and be able to work with the emergency room physician to be able to come up with a treatment plan that may or may not include hospitalization. SAMHSA says that I'm rounding the numbers, but SAMHSA says 60% of people that present to an emergency room don't really need to go to a psychiatric hospital and could be triaged to other levels of care. And this is what we really want people to do, is get the right level of care the first time and not be able to go over and over and over the same ground and get stuck in this vicious circle with them. The crisis residential is another option for treatment for folks. And this is essentially all the services that you would get in a psychiatric hospital, except there's no locked doors. You're seeing a psychiatrist daily, you're seeing nursing staff daily, you're getting your medications possibly adjusted, you're having psychotherapy individually and in groups. And it really is a very less stigmatizing way of being able to receive behavioral health services than what is currently the state of having to go to a psychiatric hospital. So, with that, any other questions? We have about 5 minutes left for questions. Go ahead.
Hi, I'm Jake Mantelfel from, I'm a doc at Henry Ford in the ER, and I think you answered it, but could you just clarify, when it comes to peer recovery, we have, I help take care of the whole system in terms of the coaches, but at Henry Ford, Maine, we have hospital-employed peer recovery coaches, and you know, there is really no mechanism to bill for those. And you mentioned that community health workers were licensed, whereas peer coaches were not. I just wanted to know if you could expand on it a little bit and clarify.
Well, it comes back to that issue that at this point in time, peer supports, recovery coaches are not a licensed provider in the state, so we can't pay them directly. If they were involved in the transitional care management, and you wrote an order for transitional care management to start, as part of that chain of providers doing that work, the peer support could be, they would be a community health worker, and that said as well. They could be billed through you to be able to get those services. And that would count to the time it's being done. So the time that they spend would be units that would turn into units that then you would be billing for in that circumstance. So it's a little bit of that really working these into how ERs do, and ERs usually don't do that. That's usually an outpatient procedure, but it's something that could be done. And just because you don't usually do it now doesn't mean it can't be figured out into the protocol.
Thank you, I follow that. And so you do reimburse for community health workers or no?
No,
Yeah, same.
not directly.
Gotcha. All right. Thank you.
But you would bill them under that bundled code, so the time they spend with the patient, but it would be billed under the DOC's code.
Correct. So there's ways to make, there's one more question over here. I guess there are ways to make this sustainable. I think it can be able to go well. It's a dialogue back and forth with the insurance plans to get the pricing right. But I think that's where we have the next work to do together. But question?
Thank you for your talk. I'm an ER doc, and I just had a question.
You're not in the mic enough there.
Are the things you're talking about, is this on? No. Are the things you're talking about covered by Blue Cross Complete?
Blue Cross Complete is an affiliate of ours. It's not directly under my supervision, so I'm not the best person to talk about with Blue Cross Complete. Basically, it defaults to primary Medicaid. There's some additional enhancements, but it's what Medicaid pays, we pay. Okay, well, thank you very much for your time today. Appreciate it. And good work.
I'm Michelle Norcross. I am the Senior Director of Safety and Quality for the Michigan Health and Hospital Association Keystone Center. And our next presentation is going to focus on racial disparities in access to behavioral health services and will be presented by Linda Zeller. Linda Zeller is the Senior Fellow Behavioral Health at Michigan Health Endowment Fund. Improving access to behavioral health services statewide is one of the Health Fund's strategic priorities. Through a partnership with United States Health and Human Services, Linda devotes half of her time to SAMHSA Region 5 as an IPA through interagency agreement, where she's working to support and create behavioral health leadership in prevention, treatment, recovery, and harm prevention. Prior to the Health Fund, Linda worked for the state of Michigan for 10 years. 2 as the Michigan Department of Corrections Health Administrator for Michigan's prisons, and 8 years as the Michigan Department of Health and Human Services, where she was responsible for community-based and state-delivered behavioral health services, including the state hospitals and forensic centers. Yet before working for the state of Michigan and SAMHSA, the far majority of her career was spent doing community-based work in nonprofits and county systems. During that 25-plus years, her work included areas such as residential direct care, case management, Medicaid managed care, behavioral health integration, and the interface between behavioral health and justice systems. Welcome, Linda.
So they told me I can walk around. Can you hear me if I'm away from this mic? All right, good, because I do not do well behind a podium. So thank you for being here. And Dr. Beecroft, that was amazing, and it wasn't boring at all. Clearly you have the right people in this room, because I'm sure you're going to get a lot of other questions behind the scenes. I'm here as a facilitator, certainly not an expert on racial disparities, but I'm really excited about the opportunity to build on some of our learning as health funders. We're just starting to scratch the surface in this important work. So today I want to talk about sort of what we know and how we're measuring things. And then I want to share just a couple high-level learnings that are happening at the Health Fund where I am, and also in some of our collaborations. You already heard about one. You just got your a taste of what's happening with New Detroit, and I can't wait for that full next part of the evaluation to come out, because I know there's lots of learning there. So what I'm hoping to do is hear from you all, because what's important in this space is sharing what we're learning, and it feels very vulnerable, because I don't think any of us feel like an expert in this space. But the best thing we can do is be a little bit vulnerable with each other and share what we're learning. So I'm going to share those 2 examples, and then hopefully others will share as well. So here's a sample of what we know. This is from the Behavioral Health Risk Factor Survey. This is Black Michigan. I should stop for a second. So the 2 examples I'm going to use are focused very much on African American, the Black community. Most of the sources are self-identifying within that community. So I just wanted to mention that the reason why I seem very focused on just that community is because these 2 examples that I'm going to give you are also focused on racial disparities in that population. So you can see here Black Michiganders and the days of poor mental health per month against the state's white population, Black women, related to mental illness compared to all women in Michigan. And then the third bullet, Black Michiganders reporting more poor mental health compared to Black adults across the country. So that's just one data source. These next 2 examples are, and I'll show you both of them. The first one is related to mental illness. The second one is substance use disorder. Going back to the first one, this is from, and Becky Sankey, please wave. She's our Director of Behavioral Health, and it was her vision to create the Behavioral Health Access Study. For those who haven't seen it, there is a link to that in a minute. But it's prevalence data, claims data, informed, and I think it is very unique in the state for sure, and the nation, and really is the stronghold as to why all of our programs at the Health Endowment Fund in the behavioral health space are focused on increasing access to services in particular, and or more things. So what this first one talks about is any mental illness, and this shows you that there's a pretty low bar in our behavioral health access study. So if you show one claim one service after you present, you're considered treated, right? One service. So that's why there's multiple colors on here, because the top bar is the absolutely untreated. The next one is somewhat treated. So what's interesting here is it raises more questions than it answers. Because if you look at this, the other category is highest. And Becky could talk about this all day and talk to you about it. I'm not going to do that. Second, population's Hispanic. Third in any mental illness is persons who identify as African American or Black. So when you look at SUD, African American Black become number one. So that's just an interesting source that you can look at. The link is later in my presentation, I believe. Where else are we measuring access and quality? So the Michigan Medicaid program and a lot of health plans utilize these 4 measures. Follow-up after alcohol and other drug abuse, follow-up after emergency department for mental illness, and follow-up after hospitalization for mental illness, and initiation and engagement of alcohol. So these are not measures we created, but measures that were already under use. Someone really smart and intuitive at the HHS said to me, you know, we look at this and we're always better than average. We always rate way up there, you know, above 50% in all of these measures as compared to other managed care entities and other Medicaid programs. But I wonder what would happen if we disaggregated that data. And would the health fund help fund disaggregating that data and studying it? Of course, that was a really exciting thing for us to do. So here's the end yet. After you disaggregate, this is a quote from the study. The link to the study is down below. So in all of my slides, you can link to the sources. And yet, in a state, this is a quote, where the quality of care in the Medicaid program is better than half the country, overall quality is not enough. Because when the data are disaggregated, there is no equity. And you can see that study, we contracted with MPHI to do that study. So here's one example. I'm not picking on Genesee, Wayne, and I can't remember who the other county is right off the bat, but I'll get to them in a minute. I'm not picking on these 3 counties because this disparity is absolutely statewide. The other population we chose to work with the African American and Black population, and the inequities in the tribal and Asian American folks who identified with that population is just as great and sometimes greater, but not as persistent across the state. So this is an example that shows, and this is from that study, which you can find online, that there's a 6.83% gap in follow-up for mental health. And some of the gaps are as wide as 30% in other examples. But when you look into the study, you'll find many graphs like this that show very specific data with very specific geographies. It's a consistent gap when you look at mental illness and SUD. There is some variation, but not a lot. So what are we learning from data? So we have learned so far that Black adults on Medicaid are less likely to receive follow-up care after a hospital or emergency room visit for mental health or substance use disorder. And building on Dr. Beecroft, I love those stats, but it's almost never a single use, and it's almost never just substance use. I don't want to say almost never, but it's often not just substance use disorder. So some more examples of what we know, using 2 different measures, 2 different geographies in Wayne and Washtenaw. That's the other county I forgot about. This is just some specifics that about the Wayne and Washtenaw gaps from this data. Again, you can get to this report at the link I showed just a minute ago. So I mentioned that the tribal group we haven't done anything with. I'm hoping that somebody out there, Community Foundation, one of the collaborative partners in MOP, university partners, that somewhere will help think through how we can do something similar in that area. So now for the two examples, and the reason I'm rushing so much is I've prompted a couple people in the room to talk about what they are also doing. My goal is that if you have something to share, if you've done work in this area, doesn't have to be focused on racial disparities with the African American or Black population that we're highlighting right now. Can be anything that you've done related to racial disparities in behavioral health. So that's just a think about what you might want to share, because that's what most of our time needs to be today. So what did the Health Endowment Fund do? This is example number one. Our board decided they were interested in funding community-based organizations that we don't usually fund for behavioral health purposes. So these are not behavioral health providers, although some are tangentially connected to prevention and other things. We picked 4 counties listed here, Saginaw, Oakland, Kalamazoo, and Wayne, and we funded one community-based organization in each county to lead a 1-year discovery and planning process. They engaged their local stakeholders, and they provided us a report. The link there links you to that report. In follow-up to that, we funded 3 of these community-based organizations to do implementation. The 4th one is very interested in doing implementation, but they're not quite ready. So Kalamazoo, Wayne, and Saginaw are all deeply getting ready, either getting ready to or have already kicked off implementation projects. So what have we learned across these 4 sites so far that did the discovery and the 3 that are beginning implementation? So our evaluators found that that you can't overstate the complexity, right? Individually, institutionally, system barriers, individual barriers, that you can't dismiss personal experience with our service system and the distrust that it has built. Stigma, racism, and generational trauma continues to impact how Black people think and feel about systems of care. These concepts I'm going over in every single one of the 4 reports, where they said the same thing. Am I fading in and out? I'll try to stand more still, sorry. Workforce. Workforce is huge and was a big common theme, right? Almost no one, we don't get to go to someone who's shared the same cultural experiences with or somewhat similar. People don't look like us, right? Don't have the experience like us. We desperately want additional providers who can represent our culture. Storytelling, outreach is critical, and storytelling from the community-based organizations, which is 10 times more powerful than anything the rest of us can build. When they're doing the outreach, it's really quite powerful. Messages about importance of seeking care and how members have found care seem to be the most powerful. And finally, change in realities. This is clearly a movement, not a moment. Stages of system change cannot be rushed. At the end of this, I'm going to play a little video right before we call on others. I think it's a 2-minute, 44-second video of one of our 4 community-based organizations, Synergy in Kalamazoo, is doing a Black Wellness Network. It's a workforce development, sharing, and supporting effort specifically to provide care in this population. So that is super cool. So I'm going to play that video because I think it's inspiring. And as you're walking out, standing between you and a break, there's also a video with no words that just shows their first big celebration and gala. And hope you'll be inspired by that. I think that's all I want to do on example 1 for now. Example two is a collaboration, and you can see the folks listed: Blue Cross Blue Shield of Michigan, Blue Cross Blue Shield of Michigan Foundation, Community Foundation for Southeast Michigan, Ethel and James Flynn Foundation, Jewish Fund, Kresge, Michigan Health Endowment Fund, and Metro Health Foundation, has formed a collaborative and led together the Black-led mental health pilot program. The aims were a couple: to increase access to behavioral health services, yes, and address historical underfunding of Black-led organizations, and support Black leadership and organizational capacity. So we funded 7 Detroit Black-led and Black-serving CBOs who each received $100,000. Evaluation is underway. Please raise your hand if you're part of that project right now in the room. Kim, others. So I am not, there's Audrey, yep. Andrea. So others probably are better at answering questions related to this, but there is some really fascinating work. And it's a very different example, much more open to what these organizations lead. While the focus is behavioral health access, it's also a variety of strategies there. And I don't have a slide on that. So here is a slide from the evaluators that shows some of the accomplishments and activities of those community-based organizations. So very unique, varied when they all talk together. That they're really, really intentionally working on connecting with behavioral health providers. Referral tracking tools are important within the CBO culture. Created outreach workshops, sustaining telehealth, a lot of outreach, a lot of intentional connection with community partners. So fighting stigma, connecting with culturally relevant and competent providers, strengthening those partnerships with behavioral health providers is a lot of what the commitment from those community-based organizations are doing. So, I've mentioned examples. In a minute, I'm going to ask Dr. Mantoffel and Dr. Gratson to share a little bit about what they're doing in this racial disparity space. Can be related to MOUD, doesn't have to be, because as we learned from prior speakers, it's seldom just one issue. Before we do that though, I would like to play, and I'm not sure who's gonna do this for me, I would like to play the top video at the link below if I could. This is Kalamazoo Synergies. Anybody know how I do that? Thank you. They've got it. So let's take a look at what Kalamazoo is doing.
In 2021, I wrote a grant to the Michigan Health Endowment Fund to do a project called Racial Disparities in Behavioral Health, with a specific emphasis on African Americans and what was the outcome after an emergency room visit.
For a version and just the community I grew up in, I saw a lot of untreated mental illness. In my own family, I saw a lot of addiction, and no one could get help about it.
So Black Wellness Network is a part of the outcome. When the grant said, what do we need to do to make changes based on what your findings are? This is one of the things that I thought we should be doing to make change.
What I see is that patients are not getting the proper treatment that they need, and therefore in the future they may not be able to get jobs, hold housing, and the stigma goes further and further.
Black Wellness Network is about bridging the gap, breaking the stigma, and building stronger Black and brown communities.
Some people don't have insurance at all, or if you have Medicaid, Medicare, you only are eligible for certain providers.
This is the infancy stages of a network geared around Black professionals, providers, doctors, counselors, nutritionists.
A lot of it is lack of education, lack of having access to providers that will listen, to providers that actually understand, and that really want to help.
If we can get a pool of providers, then we can engage in community making those connections, which would make it easier for people to follow up and easy for them to connect and engage in services.
This would just be search bar, find it, right to it. And you see it in every other field. So just to have one for our community is huge.
We could provide the accurate care that our patients need instead of providing care based on a stereotype.
The more we grow as a network, the better that we can abdicate in various areas for that.
If I can find providers on there, even if I'm not able to use those providers, I have a place to start, and we can actually get some help for some of our people that actually need it.
And so we want to lay a really strong foundation and have a really strong platform to continue to encourage people to be a part of the network. If we could be that source, I think that it would be a healthier community and nation when it relates to Black and brown people.
So just one example of the work that's happening. Their goal and their idea, and they're working with local community partners. They've had a big gala to celebrate the kickoff, which is next month, and I'll play that as you're walking out. But the goal is both to empower providers who represent the Black and brown communities, as well as work with payer partners and health system partners to try to figure out ways to make it easier for people to find those providers when they want to find them. Very early stages, super hard work. And during their gala, the common theme was, this is definitely a movement, not a moment. I mean, this is just the beginning. But it is so exciting and so energizing to spend time with a lot of these folks in Kalamazoo. So let me stop for a minute, and I think I'll start with, be thinking about what you want to share, but I'd like to start with Dr. Mantuffel. Do we have a mic for out there that we can get to Dr. Mantuffel to share a little bit about anything you're doing, learning in the racial disparity and behavioral health space? Thank you so much.
Yeah, thank you for the opportunity to share. So we did participate in the New Detroit Just Care pilot. I think that you guys all funded. And full disclosure, the participants, I think we had 20 or 25 either ED docs or PAs that were the participants that counted for our racial bias training as required by the state, and we were incentivized to participate. But I thought that they did a fantastic job. The information they shared, there was a lot of stuff that I knew about personally as a physician, the Tuskegee, the history of Black people in medicine, and why there is distrust there, and especially as it comes and it relates to drugs, the penalties associated with crack cocaine use as compared to powder cocaine use, and the communities that were using each of those substances, it was really, eye-opening even to me, and I thought I was pretty, well-informed on that, and there was a spectrum of providers that participated in that, and not all actually were that open-minded, and I think that all of us that participated thought it was extremely well worth it, and like I said, we were killing two birds with one stone, because this is required training by the state as it is. And, I just thought it was really well done, and a really good use of our time and education. And that was our experience. And so ironically, one of my interns this last year did a study from 2021 about racial disparities in our own institution, and found, of course, just like across the country, we gave buprenorphine at a higher rate to white patients as compared to Black. And so this was actually done prior to our training in early 2022. I think that's when we did it, or was it 2023? Time flies. But we did it after the fact, so that kind of is a wide open research study for us to see, at least in that cohort of providers, was there any difference in our, the proportion of patients that got buprenorphine, not the racial disparities were still.
Yeah, that one died, it looks like. Nope. I guess you're going to have to use your outside voice. We're not recording, so I think we can.
Use my other mic? That doesn't work either. Yeah, okay, there we go. I'll just keep mic'd up for the rest of the time. So I don't know how much of that cut out, but I thought it was an outstanding program. I thought we all got a lot out of it, and I think that if we are going to require these kind of trainings, very specific, provider-oriented training, I think is the way to go.
That's great. Thank you so much for sharing, and y'all are thinking about what you might want to share, right, too? There was one other person I asked ahead of time to share, and that's Dr. Gratson. And, I know you introduced yourselves earlier, but if you can reintroduce what your role is, Dr. Gratson, that would be good.
All right. Does this work well for me?
Perfect.
Jake, I apologize. I think it's just you, apparently. But my name is Michael Gratson. I'm an emergency physician at Cornell Health University Hospital, formerly William Beaumont Royal Oak. And I'm also the medical director of our EC OUD program there with Dr. Eckensweiler sitting right next to me, who holds that same title over at our Troy Hospital. So, just first some observations and what we're doing to work to address those issues, and then some other things that we're doing internally. When we look at this problem of inequalities in how we are able to serve our patients, rarely does it ever come up where it's the obvious overt racism that you might expect to see. Really, it's the institutionalized racism that really affects our patients, and it's geography. Because we're situated in Royal Oak, we see a diverse population, both racially and socioeconomically. If you come from Bloomfield Hills and you have opioid use disorder, and we're looking to connect you with outpatient services, there's just a lot more resources that are readily available for those patients. Mm-hmm. If they come from Bloomfield Hills, higher likelihood that they're going to have private insurance, so that opens up certain doors and that our Medicaid patients simply don't have. And one of the struggles we encounter, particularly with both Wayne and Oakland County, is dealing with our PIHPs. So if you're a Medicaid patient and we want to connect you, we have to first connect through the PIHP, which acts as a gatekeeper and frankly a hurdle for a lot of these patients, because at times they may offer that, to be able to be connected with an outpatient clinic to get services, you may have to undergo a 2-hour interview on the phone, which is very difficult for some of our patients to do, especially if they're in active withdrawal, just recently overdosed, dealing with other medical issues. And when we are looking at the resources that we want to find geographically close to them, so they have a much higher likelihood to follow up with those services, it's just not the same volume that we have in with our other patients. So it's the issue of geography. That's a bit tougher for us to be able to resolve that one on our own. But we have been meeting with our PAHPs to help them understand that the onerous burdens that they can place on these patients and try to streamline the process more. So when we have a patient who is, in withdrawal, they're not, going through an overly onerous process just to be able to get access to go to a clinic. So the PHPs have been responsive to that. I mean, they are working to better streamline their services, have better 24 access care to be able to get through this. So regardless of the time of day that we can have access for them. So we've been working forward on that internally within our own department and throughout our health system. As Dr. Mantuffel had mentioned, we'd actually used some grant funding from community foundations to bring in an outside expert on racial bias and stigma, to develop a curriculum and administer a course for us, which was really help break down just, how even with the best intentions, you still are going to have bias. You're going to have certain stigmas that are there, and how to better, create a constructive mechanism that you can work to overcome them. So that's what we, utilized for our providers, bedside nurses, to really help to make sure that as we're providing, care to our patients, that we're trying to take a appropriate approach, regardless of whoever is coming in through our emergency department. So those, certainly that has been meaningful and something we're continuing to look to expand on.
Thank you so much. So I saw a lot of nodding heads with the geographic institutional thing, a whole lot of that, right? And that, as a health system or hospital system, you can't solve on your own. As a community system, you can't necessarily, as a community provider, you can't necessarily solve that on your own either. So that one is tricky, and that's going to take some work. I also saw a lot of nodding heads when you talked about the example of the PHP and the difference is multi-payer system, right? With the PHP being the place you default to when there isn't coverage or when there is Medicaid coverage, right? Critical, important player, and congratulations on working with. And the PHPs can only do so much unless the state allows in our contract, and I can say this because I used to be responsible for that contract. So a lot of what is difficult didn't get fixed on my watch either. So, credentialing, federal, state contracting. So a lot of this has to be a dialogue that includes, congratulations to you, with the PHPs, between the PHPs and the state, between PHPs and private providers, right? And Dr. Beecroft challenged us a lot in what commercial payers can do and where they're building on the public system and where hopefully the public system is learning from them and building. So it really does take a village. So thank you for sharing. Anybody else want to share what they're doing? Doesn't have to be racial disparities alone, but anybody else got some work or frustrations, anything they want to share or pick each other's brains about? Thank you, Dr. Poland. Dr. Poland, if you couldn't hear her question, was asking to share a little bit about the change the state made, and I can't remember how long ago it was, maybe 2 years? August 2021. Dr. Poland probably knows the hour. So the PHP CMH public system was built for a very specific reason, to serve a very vulnerable population. So there's a lot of bureaucracy that is built into that system that makes it hard to come in and out. And a lot of that was built for that safety net public patient. Some of it works well, a lot of it doesn't work well. That was true when I was there too, so I feel some ability to say that. And however, especially when you're trying to meet people where they are and you're trying to expand to serve everybody, it's difficult. Models like the CCBHC are making it easier, but that's not statewide in the community, right? So there are a lot of barriers. So a few years ago, inspired by some of our grantees and other grantees who are doing work in this space, the state was challenged and the Medicaid policy people stepped up to their credit and said, so it may not be wise or possible for every provider to do all of the things that a PHP is required to do when they are built for the public patient. So for the providers who are trying to serve people other than the public patient, let's allow them to bill the state Medicaid proper. So what's the code, Dr. Poland? I can't remember. Do you remember?
It's the same, but it just goes through chance. So
Okay.
if you bill 99213 or whatever in your outpatient setting, there's also counseling, collaborative care, urine toxicology screening, blood work, all of those kind of ancillary services are also
So did anybody have trouble hearing her, or did you get that all? You got that? Okay. So I can tell you this is a very underutilized code right now. It's getting more and more, but to Dr. Beecroft's point about sustainability, this is one where if you're designed, and hospital-based outpatient behavioral health providers should be our number one there. It is difficult for credentialing reasons for an outpatient behavioral health provider in our state to meet the credentialing and contract requirements that the state requires of the PHPs that they then pass along. It is nearly impossible, especially from an accreditation standpoint, because when you get accredited for Joint Commission as a program within a health system, very different credentialing requirements that are difficult for the PHP to meet their requirements and yet, okay that credential. So it is exactly for all people who have those kind of programs that this kind of system was built. So can't do, whoa, sorry, I was trying to talk up. If your system just has made the decision not to become part of the PHP or can't quite because you're built for something else, you stay would have built. Sounds like maybe I need to turn off my mic and go back over here. Is that what I need to do? Getting a lot of cutting in and out. I'll stand here. So anyway, there's lots of room to see people when they come to you, see them in your outpatient systems. And, however, please continue to work on, I know several of you have become PHP providers for specific purposes, opioid health homes as examples. Those are really good. So anybody else want to share anything they've learned or are struggling with related to disparities in racial disparities in particular, or disparities or inequities in general? I know there's a lot of good work going on. Yes, can we get a mic right down here towards the front? And then if you could introduce who you represent today. Thank you.
Hi, I'm Maureen Ford from Bronson Health Systems, and I'm here with my team, Kristen Vizzo, Paul Bodenberg, just a couple of them. But we had the grant. I'm an ED doc. We did all that. And I guess I had a question about the program, the pilot program that you did at Henry Ford that Jake was talking about. Like, is that something you're going to disseminate to other hospitals? What's the plan for that? Because in our experience in this work, when we started it, we thought a lot of it was about just building the system, building the support the providers needed, which we've done. But I think that when we look at the people that are actually prescribing, we've got 40 ED docs and 20 APPs across 4 emergency departments in Southwest Michigan. So it's a big group. But one of the MI Open 3-hour training that was reimbursed for physicians, we got about 40% of our providers to go to that. And to be honest, it was because of the reimbursement that we got such a good turnout. So, and it shouldn't just be for physicians and APPs, it should be for nurses, because anyone who works in healthcare knows that nothing's going to happen in a place where we take care of patients without everybody, especially nurses, on board. So, and the stigma is huge. Like we all say that, but once you really start doing this work, you see it. So even though they've trained in it, some of them are prescribing, and we are still seeing the, words, inappropriate words in the chart, and stuff we talk about with them. But what is the plan for moving that work forward? And I'd love to be able to do that in our system. And we're going to our counties for opioid settlement donors to see if we can use any of that work for this type of continuation, because it's really about the people and just hearing those things and then carrying it forward and providing that welcoming environment for patients.
Thank you so much, and thanks Bronson team for being here. There's a lot of other things we could talk about that are really cool that the Brunson team is leading and doing in this space and others. So we really appreciate you being here. I don't know who wants to take this question. Who's best? Well, first of all, let me stop for a second. Raise your hand if you've been involved in the New Detroit work. In addition to Dr. Mantoffel. Okay, I guess you're it. So, and Marissa. So the question is, can we expand it? How do people know about it? What are the products? How can we replicate, et cetera, et cetera? So it looks like Marissa's going to help you out, Dr. Mantoffel, and then we can go back to you if you have more to say. You're also getting your steps. Hope you have a Fitbit on or an Apple Watch.
Yeah, so is this? Oh, there we go. Okay. So the New Detroit training, it's owned by New Detroit. And so we helped fund that. So like, again, so New Detroit has a Just Care training module. So if you go to their website, you'll see they have multiple Just Care trainings. It's a whole suite. And so what Vital and the Community Foundation worked together to do was to create like that really specialized version, which is what Dr. Mantoffel, one day I'll get your name right, for the pilot training. And so now that Hopkins, I know this is a lot of different organizations, now that Hopkins is like finishing their evaluation, I think they're assessing, what's next, like how do they expand it? How do they let other providers take this training too? So that's not a clear answer because the answer is TBD. But yeah, hopefully as that evaluation, I'll just yell. As that evaluation informs what the training looks like maybe they'll expand it from there. So I don't know, Emily, if you have anything to add.
Oh no, I was just gonna say we can connect them still.
Yeah, we can definitely still connect anyone that's interested. So yeah, send us an email and we can loop you into something with New Detroit and see if they're interested. Yeah.
Just for purposes of the other funders who are here too, raise your hand if you're representing a health system that might be interested in looking at that training. Okay, good. Yeah, that's great. So that looks like something you're going to get some interest in. How do we replicate it? What does it cost? How do we do it? And don't forget your community foundation and your local health fund partners too, because in addition to opioid settlement, which make sure you're talking to your localities, your townships, your counties, your cities, right? And making sure they know how important this priority is. In addition to your community foundations too, because some of us have limitations in what we can fund, and sort of one-time things are much easier to fund than things that are going to require ongoing. So just another pitch that the public-private partnership can really be helpful. Dr. Mantoffel, anything to add to that?
Not really. I do think that it would be very useful for other docs to be able to take that kind of training. I mean, it's good for medicine, period, and why there's distrust within the Black community with regard to medicine already. And so you kind of have like that double whammy, where you have a stigma related to OUD, and then already, there's a lot of bad history, frankly, about the treatment of Black people in our country by the medical system. So I just, it's really eye-opening, and I think it'd be just a really good use of, especially to meet that state requirement that we have. I think that was it really got to the core of that, of why Dr. Calhoun and the governor, decided to pass that requirement, or I'm not exactly sure the legislative process behind it, but I think that kind of training that we receive actually hits at the core of what you want to get out of us.
Thank you very much. Anybody else want to share or have a question for a colleague? Yes, the Bronson table again. Yay. That's good. I didn't see any other hands.
So I'm also from the west side of Michigan, but actually Grand Rapids. So I'm here with my partner from Corewell Health. This is Dan Wicklin, who's our nurse educator, and I'm the addiction medicine director. So I work outpatient. I'm not an ED doctor. I'm med peds. And then Josh is actually from a community-based organization, also from Grand Rapids. But one of the communities I wanted to say that we have a lot of interaction with, that is something I wanted us to think about, is our communities of gender diversity, so the LGBTQA communities. So we're finding, especially with our young folks, a lot of overlap with especially our transgender folks, transgender populations of color. So there's a lot of overlap with chemsex, folks who are engaging in survival sex, who have high risk for things like substance use, as well as injection drug use, which puts them at risk for things like HIV and hepatitis C. So we're seeing a lot of that type of overlap, which I didn't see addressed in the presentation today, but we are seeing that group in particular as well, which is, a couple of Venn diagrams which are overlapping.
Yeah, that's great, and thank you, Corwell, and thanks, West Michigan team. That was not, there were several areas. You can't cover them all in 45 minutes in any depth, and however, I think we could have done an entire session on this particular area of disparity, and I know others are doing really good work in this area. Dr. Poland? Thank you for that reminder, Dr. Poland. I probably should have had that in my slides. I probably should have had the link to the advisory committee, opioid advisory committee website, because it is deep in information. And especially when you're trying to talk to the local administrations and bureaucrats who are overwhelmed, because in addition to opioid settlement dollars, they are also worried about clean water and PFAS and you name it, and roads and all that kind of stuff too. Dr. Poland? Oh, Amy's here. Yes. Or wave higher. There you are, Amy. Thank you. Yes, thank you. Thank you, Dr. Poland, for raising that. And Amy, thank you for your work, because it is super important. The county commissioners and the city leaders have 100 major challenges, and this is one of them. And Amy, thanks to Bloomberg and Vital Strategy, is embedded in the Michigan Association of Counties specifically for this purpose, to help make sure they have the information they need, to help make sure it's easily accessible, to help liaison between each. And I already had the 5-minute warning. So Amy, anything you want to say or any advice you have for us? No, that's okay. Okay, thank you. So in closing, I would like to play that second video, so I'm not sure who wants to relate. Let me key it up for you what this is again. This is Kalamazoo, and I'm sure the Bronson Corwell table, the Bronson people there will recognize some of your leadership in this next video too. So that Black Wellness Network is getting off to kick off in a major way in October, again for multi-purposes, strengthen that provider network, build it out, make it easier for health systems when they're trying to find an individuals, when they're trying to find a provider who can also represent that community. So are we ready? All right, we're good to go. And after this, you can just leave.
This is Black Wellness Network. This is our first event.
thank you for all that you do. I mean, you're really bringing this community together.
Elder Val and her team is going to be working diligently to ensure that we fill up this network with every single health need we possibly have. I'm reclaiming everything my ancestors prayed for, rebirthing legacies that got left at shores.
I say here that we are determined here in Kalamazoo, Michigan, that we are going to work and fight until justice runs down like water and righteousness like a mighty stream. I think that we can come together and we can do the work of racial healing.